I had a case of working backwards, and rather than fitting the medications into conditions, it was a case of understanding the conditions, normal functioning of the heart and the vascular system before I could apply those medicines in the case. And similarly with arrhythmias, out of the three main stems or the three main branches of cardiology practice, so ischemia, heart failure, and arrhythmia, I think arrhythmia is poorly understood in general. It's quite complex, and it does require a degree of understanding of sort of basic cardiac electrophysiology and so on. So we will start with that. And that very much leads us on to sort of the learning outcomes for the next sort of 45 minutes or so, is understanding the pathophysiology behind some of these arrhythmias, why they occur, and really just delving into the medications. And hopefully, I'm confident that we will develop a better understanding as to some of the agents and their classes and why they're used for particular arrhythmias and so on. What I would like to say at the beginning is, of course, this is just very much guidance. It's not strict, and as you probably know from sort of your own practice, is particularly cardiology patients or patients who present with arrhythmias vary. It's a very MDT approach in terms of their management, and if I'm completely honest, no two patients with arrhythmias are the same. It's very individualized as well. So do take the principles from this session, do understand the science behind it, but of course taking that holistic view when managing your patients in each of your settings. The first thing that we want to really talk about is sort of or revisit is really the anatomy. So these are diagrams which I'm sure you've seen. I shouldn't really need to revisit this, but it's really around the structure, the anatomy, and where sort of general circulation is. On the right hand side, we've got some the coronary supply to the myocardium located as well in there. Next slide is very much just again direction as well as sort of valvular structure. So we've got our tricuspid valve on the left, our mitral valve, which is a bicuspid valve, on the right. What we don't see is obviously the pulmonary valves in that sort of bottom diagram there. On the right, sort of the animation that you can see obviously a thickened left side of the heart, and as the mitral valve on the right side closes, we can see the aorta open, which is the top. I don't think I can use the mouse. I might be able to. So there's the aorta opening there. The pulmonary valve is at the back here, and there's our tricuspid valve on the right hand side as well. So in terms of what we were alluding to in terms of cardiac output and heart failure, it's more significant when it's left-sided, particularly because the function of this part of the heart is to provide circulation and blood to the rest of the body. Automaticity. So one thing that the first thing that I do want to start off with is really this principle on automaticity. So some of you may have heard of it, and for others it may be a new concept. In essence, what we're trying to say is, without any innovation from the brain, the myocardium has the ability to generate an impulse. And this is particularly the case when it comes to the pacemaker components within the heart. And this is the sinoatrial node, that atrial myocardial cells which surround that, the atrioventricular node, and the bundle of His and the Purkinje fibers. So what we're saying is actually there is, if you were to sever off any connections to the nervous system, the myocardium on its own would be able to generate an impulse. And at the rate that it does that depends on where that impulse is going to stem from. So what we usually refer to as our primary pacemaker of the heart is usually the sinoatrial node, because in most cases there is 70 depolarizations per minute. We'll come on to what that means in a moment. In actual fact, if you were to sever off any nervous system innervations to the myocardium, the sinoatrial node would probably beat a lot faster than that. It would beat at 300 depolarizations per minute. Or there would be, 300 depolarization per minute, not in terms of beats, but in terms of impulses which are generated. And of course, what stops that from occurring is a parasympathetic innervation to the myocardium as well. So it's a combination of both sympathetic and parasympathetic, our fight-flight response in most cases, which either stimulates and increases heart rate or vice versa, reduces heart rate and so on. So this principle of automaticity exists in our pacemaker cells of the heart. and in the surrounding tissues of the atrium. Just that point at the bottom, in terms of the ventricular myocardium, does not in itself possess the ability to have automaticity, although you can get the generation of escape rhythms and so on. But really what we're talking about is usually atrial tissue and so on. That really leads us on to this next question. Well, actually, we have impulses which are generated from our nodes, which we've just alluded to. But what about the cardiomyocytes which exist around the nodes? And they themselves require, the difference between the non-nodal action potentials is that they require a neighboring cardiomyocyte or a pacemaker cell to stimulate themselves. Okay, whereas the nodal action potentials are generated on their own, they don't require innervation by themselves. So it's important that we kind of understand this sort of I call it the cardiac pylon, and understand what these action potentials look like. Okay, so I'm just gonna focus on this. I'll put the link in where I've taken this image from at the end, so others can find the video. A lot of information going on this, and what I do want to do is spend actually quite a bit of time talking through what this diagram shows. What we see in front of us is very much one cycle or one cardiomyocyte cycle in terms of impulse or action potential, as we call it. So the scale that we have here is in millivolts. And we've got positive at the top. Hopefully, I will use my mouse so you can see, and hopefully you can see my mouse circulating around on there. So we've got our positive sort of millivolts here, electrical activity, and we've got negative down here. And this entire diagram, which we're going to go through, is very much one cycle for that one action potential, one cardiomyocyte undergoes as an action potential. What we're looking at here, by the way, is a non-nodal action potential. So this action potential here is not the impulse that is generated at the SA node. It's not the impulse that's generated at the AB node, and everything that we said. We'll look at that on the next slide. What we're talking about here is any of the cardiomyocyte within the atrium will generate such an impulse. So what's actually going on? Well, on the left-hand side here, we have certain cations or certain electrolytes and what they prefer. So calcium, for example, prefers a membrane potential that's very positive. So it prefers membrane potential of 123 millivolts in this case. Likewise, sodium prefers a positive, maybe not so high, but also a positive membrane potential. That's opposite to our other cation that we see, which is potassium, which prefers a more negative state. Here in this case, it's minus 92. So what we're saying is, generally speaking, if there was no other cation involved, if it was just potassium, then the membrane potential of a cardiomyocyte would be minus 92 millivolts. Likewise, if there was no other electrolytes involved and it was just calcium, the membrane potential of that cardiomyocyte would be 103 millivolts. So what tends to happen here is, if you look at our first diagram here, this is one cardiomyocyte, and generally speaking, sorry, this diagram has been adapted, but I'll talk through it very quickly, is you see these gaps in between the cells. These are referred to as gap junctions, and these exist, allowing certain electrolytes to seep in and seep out. So as we know, inside a cell, we have more potassium than we do outside the cell. So when we look at our labs on our systems, we recognize a normal potassium level is between 3.5 to 5.5, for example, which is very small. And our sodium levels are high, which are 133 to 150, 154, meaning extracellularly, where our blood samples are taken from through the plasma, we have a significant greater number of sodium molecules outside. Hi guys, are we back in? Can you hear me?
Yeah.
Wonderful. And can we see the screen again?
Yeah.
Yeah, excellent. Sorry. Technology, yeah. It was only a matter of time before that happened, and I'm sure it may just happen again. We'll keep going. So, just like I said, this is probably the most difficult bit to understand. So just stick with me this at this point. We just need to make sure that we're understanding what's going on here entirely before we focus on sort of the medications. This is very much how the medications are applied by the understanding of this sort of initial action potential. So what we see is in this initial cell, in this first cell, we've got these gaps here. These are known as gap junctions, and what they do is they allow this cell to exist at a resting membrane potential of, let's say, minus 90 to minus 92. So what we tend to see is we tend to see this potassium molecule which kind of just drifts out and maintains the resting membrane potential of minus 19, and this carries on going on. So that's this bit on this graph here at the bottom here. So this carries on going until a neighboring cell comes along and actually throws in a bit of sodium. Okay, so through these gap junctions, what we then get is little bits of sodium and calcium and everything else just entering in very small amounts. And it does that again to a neighboring cell, and it carries on doing that until it reaches a potential here, which where this purple line is what we call a bit of a launch pad. It's known as a sort of threshold, and when it reaches about minus 70 millivolts, it opens up these sodium channels here. So as you can see by the name here, is that these sodium channels are not ligand gated channels. They are what we call voltage gated channels. And how do we know that the voltage gated? Because actually when the membrane potential has reached minus 70, these channels have opened up. So you get this massive influx of sodium which comes into the cell, and we've got this massive steep rise which takes the potential of the cardiomyocyte into positive. Now, this phase here, so when it goes away from negative to positive, we call this depolarization. So whenever you look at sort of what's going on in an ECG, which we look at and so on, we talk about atrial depolarization or ventricular depolarization. What we're essentially saying is that the membrane potential has gone from a minus negative number to a positive number, or to a degree of it being positive. Okay, and what tends to happen here is it gets to a point where it gets to about, let's say, plus 20, and all of a sudden these sodium channels by themselves, they shut. Okay, and if they hadn't shut, what would happen is that plus 20 here would carry on going all the way up to plus 67, which is what sodium as an electrolyte would prefer. But what happens is when it gets to about 20, these sodium channels close themselves. Okay, at the closing of these sodium channels, again, what happens now is we get the opening of something known as voltage gated potassium channels. What I want to draw your attention to here is on this first diagram on the left here is this potassium channel is part of a gap junction. So it's just very much potassium leaking out. It's not via any voltage gated potassium channel. But here, what we've had is a rise in millivolts, a rise in membrane potential, which has automatically triggered potassium leaving via actual voltage gated potassium channels and stuff. And what this does is we see this slight dip in membrane potential, because remember what we alluded to earlier, potassium prefers to be negative. So there's a bit of a to and fro, a bit of a fight going on here. Potassium wanting to return to its negative state. Sodium initially has just caused a massive rise. But what tends to happen is there's an incredible change which occurs at this point when there's a slight reduction in potassium. Where there's more potassium leaking out, and when it initially starts to head towards repolarizing. And what happens here is a slight reduction or a slight leaving of potassium actually stimulates some calcium voltage gated calcium channels to open up. And this this image is quite simplified, but it's not to say that these channels appear out of nowhere. These channels are always there, and they exist as part of the cell. But the difference is that these are voltage dependent. So these calcium channels were just going to open when there was that slight dip in potassium from 20 to 5, plus 20 to plus 5. And again, we've got this a bit of war going here. So potassium wanting to return downwards, calcium wanting to maintain a positive sort of trajectory up towards that 123. And what we get is this prolonged period of equilibrium as such, and we got this phase which is known as phase 2. It's known as the plateau phase, in which calcium is trying to depolarize and potassium is trying to repolarize, up to a point where actually we lose the amount of calcium that we have. I'm not going to go into too much of that, and eventually potassium does end up returning back down to its natural state of repolarization. Okay. And what we're saying here is that this is one cycle. After phase 4, this then goes and stimulates the cardiomyocyte in the next, which is adjacent to it, and so on and so forth. Okay. Again, I'm just revisiting this. So what we have is this repolarization, which is done by this initial steep rise by sodium entering the cell. We've got an initial dip with potassium now sort of wanting it to return back to the repolarization phase, a plateau phase with potassium and calcium channels open, and then our calcium channels shut, and we're back down towards a repolarizing phase in which potassium channels are open. Okay. Naturally, in terms of the resting membrane potential, what we refer to as the resting membrane potential is this first diagram. So this is the natural state of cardiomyocytes when they are not stimulated. And again, please note, these are non-nodal cardiomyocytes. These are non-nodal action potentials that we're looking at in front of us here. A summary of nodal and non-nodal is in that bottom image there. So on the left here, the diagram that's been neatened up here is of a non-nodal action potential, and on the right hand side is a nodal action potential. What I'm just going to show you in the next slide very quickly, less significant at this moment in time. Main thing was to understand this image was the difference between this non-nodal action potential, which is referred to as a fast action potential, and a slow action potential. So here it's quite similar. So what we're saying is if someone has a heart rate of 60 beats per minute, this entire cycle of action potential takes 1 second, because it's 1 heartbeat per second as well. The difference here is that there is no plateau phase on a nodal action potential. So what we're essentially getting is an input of sodium and calcium, and then it just very much opening up potassium channels on the right, on this right hand picture, and potassium channels leaking. And so we kind of get this sort of wavy graph as opposed to this one on this slide. Okay. And I won't talk any more about this, just predominantly because it can get a little bit overwhelming, and we've just sort of more or less started this. But what I do want to say at this point is any antiarrhythmic which is used for the various types that we're going to discuss today predominantly focuses on these two graphs. The mechanism of action is dictated, and its effect is dictated on the changes it has on these two graphs. And again, if you want to develop some of that knowledge on sort of the pharmacology of the drugs and stuff, I would just advise you to sort of revisit this electrophysiology. You may be able to sort of hear it in a better way than I've explained it also, but hopefully it does make sense as to what I've tried to say there. And this, when we map it across into what's going on, so this is a neatened version. So what we're saying is our SA node, which is our primary pacemaker, will fire off which sort of action potential? A nodal action potential. Can you see that graph? So that first one is not a non-nodal, it's a nodal action potential. And the tissues around it will very much stimulate this a non-nodal action potential back down to the AV node, which is a nodal action potential, and then remaining tissues look a lot more like our non-nodal action potentials which occur. As to how it's mapped across on an ECG, so what we tend to see here is initially we've got obviously our atrial depolarization, atrial repolarization, ventricular depolarization, ventricular repolarization. And again, a third graph here just to mimic exactly what we're saying. So do go away and have a look at what that electrophysiology is, how it affects obviously an ECG, and it would probably, I'm not an expert in terms of interpretation, but it would probably help you interpret ECGs better and sort of form a diagnosis by understanding where those changes are in terms of electrical activity. In terms of where arrhythmias fit in, obviously, first thing we need to know is actually how do we recognize the rhythms are obviously abnormal? Are we concerned about any primary pacemaker, or are there any latent or aberrant pacemakers which are dictating play? So when we look at our re-entrant tachycardias and so on, it's very much a pacemaker which has superseded the sinoatrial node. This could be due to, obviously, like I said, it could be due to a re-entry mechanism. It could be due to any other form of automaticity in which any of the nodes are firing excessively. So we'll have a little bit look into that. Obviously, the arrhythmias that we focus on are not just tachyarrhythmias. There are arrhythmias which, when it comes to sort of nodal and atrial effects, we usually look at sort of any arrhythmias which can be both tachy and brady, which are to do with diseases of the AV node and SA node in there. So our patients with tachybrady syndrome who require pacemaker and beta blockers as their form of treatment and so on. So I'm just going to skip through this. In terms of very much the arrhythmias that you probably are familiar with in terms of SVTs, in actual fact, SVTs are any of these listed here. So even our AF is technically a supraventricular tachycardia of some sort, but in clinical practice, we tend to refer to SVTs except for flutter or fibrillation in most cases. But just by sort of a literal definition, it's arrhythmias which originate in the top chambers of the heart. Of course, in terms of flutter, what are we looking at? We're looking at sort of this F wave, flutter wave, and the difference between that we see with flutter and AF is very much the regularity of the block. So we can get 2-1-3-1 conduction, whereas in AF it's very much irregularly irregular. We get this sort of sawtooth. Have I got an image? I don't think I've got an image on or more with the flutter, but we've got this sort of sawtooth appearance in that. What we've alluded to previously is actually, remember, the atria can actually conduct at, let's say, 300 beats, and therefore what we're saying is it's really down to the AV node to block some of those signals transponding down to the ventricles, and that's why some of those signals don't, and that's why we say someone's got a 2-1 or a 3-1 block in that sense. In terms of AF, obviously we define it in terms of regularity or irregularity. That's the diagnosis initially, but in terms of duration, so again, some resources talk about how long a patient has been in AF or how many episodes they've had. Of course, there are various risks. Some are sort of idiopathic, some may be sort of related to alcohol. My sort of broad definition of sort of AF and whether to treat and whether to not is very much the recurrence of it, how long they've been in there, any other risk factors which can be or cannot be addressed. Of course, if you're going to have excessive amounts of alcohol or caffeine and so on, then you're at a higher risk of going into AF and or having some sort of tachyarrhythmia in that case. I think the second thing is it's about threshold. Everyone has a different threshold in which they may be okay having so much to drink or a certain amount of caffeine, and they are not symptomatic. They don't get palpitations and so on and so forth. But actually, once they breach into a threshold, they are permanently within that state or until that period has elapsed. So, yeah. And just a question to the audience, just to make sure everyone's still there, is really why does AF pose a stroke risk? What's the actual sort of pathophysiology or the physiology around that? Why are we concerned about AF and stroke? Sorry, I can't see the chat function, so you may need to either unblock or just filter some comments through.
Is it because you get emboli forming behind the ventricles? Behind the mitral or behind the atrioventricular valves?
Yeah, excellent. So it's round sort of the atrial chambers. What's that area called? And the name? Sorry, I can't see the comments. So, Helen, I don't know if you wanna.
Yeah, I can see them. So Haley said also for the clots formed from static blood in the heart chambers.
Yeah. So where's that chamber? So we've alluded it's around the atriums. Any atrium in particular?
So Suzanne's put that the atria doesn't fully empty, and anywhere blood is static, it will form a clot.
Yeah, good. So usually what we're concerned about is the left atrium. It's usually a concern, particularly if patients have a dilated left LA, but also an area which you may have seen or may have heard of it referred to is known as sort of the left atrial appendage, which can come in different shapes. Some people refer to it as a wind socket, other people refer to it as sort of like a cauliflower shape, and it's where blood tends to pool in sort of this left atrial appendage, which eventually over time causes stasis and a clot, and it's very much once that travels, go away, have a look at some echo images of sort of left atrial appendage occlusions and stasis, and any thrombus formation there, and it looks quite daunting to be honest. Couple of sort of treatments for that, as well as we tend to put patients on anticoagulants to prevent sort of the stasis and thickening of bloods. But you can, I know certain centres do such a thing called Watchman device, which is very much there are sort of other devices out there which very much seal off that left atrial appendage, so blood doesn't actually enter that. But that's obviously surgical intervention, and some patients who are probably not suitable for anticoagulation, that may be an option for them as well. So excellent. Like I said, just in terms of the biggest difference, it's to do with sort of AF tending to be sort of irregular. But of course, on ECG, we don't see those P waves on there. Acutely, our sort of concern is patients who present with fast AF, where the heart rate actually is increased. So two sort of pictures really that you see. You either see those F waves present, or without the F waves, you see this minor oscillation of the sort of baseline. Sorry, I'm trying to move them also. Of the isoelectric line at the bottom there. In terms of other types of SVT that we're looking at, what's that? Very quickly. Say what you see.
Wolf Parkinson White.
Yeah. Okay, so very much around a re-entrant tachycardia, and you've got this slurred uprising of this delta wave here, but the images there really, I think it's self-explanatory. It's just showing you what's going in terms of circuit change and on why it occurs. And again, I just want to emphasize this when it comes to medications, just we'll revisit some of the terms here, and hopefully it should make sense to you as to why those medications are used for certain indications. This is alternate to our AV nodal reentrant tachycardia, which is very much a defect within the node itself. Again, I don't want to spend a lot of time in there, but basically within that node, there are two types of action potentials which fire. There's a slow action potential and there's a fast action potential. And what we realize is if both start off at the same time, the fast one would finish. The action potential would finish a lot quicker, and there would be a longer refractory period. The refractory period is a time where another action potential cannot fire. Now, what tends to happen in patients with AVNRT is that the shorter refractory period and the longer the slow action potential and the fast action potential within the node to a degree overlap one another, and you don't get this refractory period in which action potential isn't fired, and you just get this sort of repeat premature beats which continue as well. But do go away and have a look at sort of again at an action potential, what that means. But what sort of action potential is this one here within this node? It's not going to be a non-nodal action potential. It's going to be a nodal action potential. So just the one with a slight slope up and down. For time. Okay. In terms of management, SVT management, we talk about sort of vasovagal stimulation. So we do your Valsalva maneuvers, vasovagal maneuvers. And really what we're trying to do here is we're saying that these patients don't have a degree of sinoatrial disease. And therefore, by stimulating the parasympathetic nervous system or the parasympathetic divisions, we will get a reduction in heart rate. Okay, so whether it's swallowing ice cubes, whether it's sucking your thumb, any sort of vagus nerve stimulation or vasovagal maneuvers can reduce heart rate as long as there's no obvious sort of sinoatrial disease. Obviously, the last few there in terms of carotid massage, it's not something that unless you're trained to do that or you can assess, you'd want to do in case there's any abnormalities there. And again, just I've just put that last point in there, just managing constipation in cardiac patients. It's often done and it's fine, but just it's important that we address any constipation issues, because actually constipation is pro-arrhythmic in itself, because you are potentially inducing bradyarrhythmias, stimulating sort of the vagus nerve. Also, as well as constipation, the treatment of constipation in terms of laxatives or beyond that in terms of enemas. Enemas can irrigate the vagus nerve. So actually use them when you need to restrict them, sort of restrict use to sort of micro enemas, rather than any foam or liquid enemas which would travel further up. Yep, so that's just a point on there. This is from the Research Council in terms of management, which we're going to come on to in terms of drugs as well. But I don't think there's anything on this diagram which you shouldn't be familiar with. It's quite straightforward. I think it's pretty neat, looking at sort of the QRS complex. If it's narrow, looking at the regularity of it, and that's where we can or cannot use adenosine versus sort of any other rate control. And on the other side, in terms of broad QRS, what we're saying here is that the signal that's transponding down, the action potential which is going through QRS. Remember, the QRS phase on the earlier diagram was very much ventricular depolarization. So what we're saying is anyone who has a broad QRS is actually that depolarization, which is occurring through the bundles and the Purkinje fibers, is actually taking a bit of a longer route around it. There's different reasons for that. So patients can have a bundle branch block. Obviously, if that's known, then you can account for that. And it may be that you manage those patients according to someone with a narrow QRS, because that bundle is a known pre-existing bundle in that sense. Excellent. So couple of ECGs there, also a couple of strips there. Our two shockable rhythms obviously are VT and a VF, and our two non-shockable rhythms where we're reversing our H's and T's are our PEA and asystole. I'm gonna skip. I might come back to this. I'm just gonna skip this bit here. Sorry. Okay, Vaughan's-Williams classification. So a big build up to it all. Big build up to the medications. A lot of physiology. Now coming on to some of the medications. What I want to ask you is, has there anyone heard of this before, Vaughan's-Williams classification? Yes, no?
No.
No. Okay, so I'll take that as general. So what we're saying is, when it comes to antiarrhythmic management, most of the classification of antiarrhythmics are defined historically in this classification system. Now, the four classes that we're going to look at briefly are sort of this class 1, class 2, class 3, class 4 antiarrhythmics. But we're going to what I do want to say is that this is a very historical classification. A lot of more evidence that's come through and a lot more clinical use has shown that actually there is overlapping use. But for the purpose of this teaching session and for the purpose of understanding management of arrhythmias, I think we'll stick with the broad the definition and sort of the majority affinity for these drugs and their receptors. So what we're saying here, broadly speaking, is class 1 very quickly. And like I said, my aim is that within 10 minutes, we are able to understand antiarrhythmic drug management. So it's a big challenge there, but I'm confident that we'll do that. So class 1 is very much sodium channel blockers, class 2 beta blockers, class 3 potassium channel blockers, class 4 calcium channel blockers, and few of the bits that we use in arrhythmia management alongside it. The first thing that we notice is out of those 4 classes, 2 of them are rate control, 2 of them are rhythm control. Class 1 is rhythm control, class 2 is rate control, class 3 is rhythm control, class 4 is rate control. And in terms of the management of arrhythmias that we see in daily practice, that's a question we should be asking. Do we need to rate control? Do we need to rhythm control a patient? Particularly with atrial arrhythmias, rate control tends to be a little bit easier. Rhythm control certainly warrants cardiology input into that, unless you have some guidance that's already published or and written, which allows you to make those decisions on that. So the first one that we want to look at is our sodium channel blocker. And the first thing that, well, the obvious thing that you'll notice is a diagram in the middle of this slide, which looks similar to what we went over at the beginning of the session. Now, what you're going to be able to hopefully tell me, and like I said, we're not face to face, so I'm going to kind of speak on your behalf on this, is that diagram's telling me that this class of drug, whatever class of drug it is, this class of drug is causing a slope on the depolarization phase, and as well as causing a sort of initial slope, that slope is then sort of delaying everything else that proceeds. What you'll also tell me is actually the width of that diagram of the actual action potential is probably not, it's wide, but there's not a massive change in terms of the length of the action potential that we see in front of us. So class 1 sodium channel blockers, there's some examples there. Disopyramide is one that we use. Quinidine, have you heard of quinidine? You might be more familiar with another drug called quinine, which is an enantiomer of quinidine, so they both go hand in hand. There is some evidence that quinine would be sort of cardioprotective. Otherwise, at the same time, it could also be pro-arrhythmic. Procainamide is one that some centers use. We don't use it here. So the only one that we use here is disopyramide in oral form. A couple of indications listed there. We tend to use disopyramide in some patients with hypertrophic obstructive cardiomyopathies as well. But it's also important to use AV blocking drugs. I'll come back to why that's the case as well in a minute. So a quick way of sort of remembering this is DQP, so double quarter pounder. So disopyramide, quinidine, procainamide. That's why that burger's there. So double quarter pounder to remember our class 1 sodium channel blockers. So remember what we said, just why is there initial reduction? Because we are slowing down the rate of depolarization. We are blocking the sodium channels, which would cause that acute and fast massive rise from -92 to towards 67. And therefore, that's why we see that slant. Hi guys, can you hear me? I'm back.
Hi, yeah, we can hear you.
Yeah, cheers. Thank you guys. Sorry, we can't help this, but we'll keep going. Just gonna share the slide deck again, so hopefully you can see that again. So what we're saying is this is very much our double quarter pounder calcium channel blockers class 1A. And keep an eye on that bottom bit in terms of the effects. So sodium channel blockers, we'll look at them. So class 1C most potent in terms of blocking ability, class 1A, class 1B, increasing the effective refractory period at the bottom. So class 1A again, in this case, the most potent, then class 1C, class 1B, least. We'll talk about what that means on this next bit here. So our second slide here is class 1B sodium channel blockers. So this is taco with more lettuce. Very much our choice and our class of drug for those patients who are having any VT post MI. So if you've not already noticed, you'll often see patients who have any VT post MI going on to lidocaine infusions, patients who have refractory or chronic recurrent VT. As an outpatient, they may be on mexiletine, oral medication as well. And the reason for that is actually out of the sodium channel blockers, class 1B is the least pro-arrhythmic. Now, you're probably thinking, hold on a minute, aren't we using these as antiarrhythmic agents? Well, all of any agent which has antiarrhythmic properties also has the ability to be pro-arrhythmic, except sort of one or two. So a large number of antiarrhythmic agents can be pro-arrhythmic as well, and that's the reason why we have all the monitoring in place in that sense. So what are we seeing with here? Well, actually, we don't see a shift in the sodium channel blocking. So in terms of depolarization, we don't see a massive change. But what we do see is, if anything, we actually see a shortened action potential. Naturally, what we would say in this case is this would cause a faster heart rate because the action potential is actually shortened. You're actually going to get more action potentials firing. But this class of drug is pretty effective in patients post-MI. I can go into the detail. I'll just very briefly mention the reason why this class of drug is used in patients post-MI is because of the ischemic tissue that's present. So a lot of the ischemic or infarct tissue that's present is naturally locked into a state which it's already depolarizing or it can't depolarize. So the thing that I mentioned earlier about these action potentials cascading off one another, that can be a problem when you've got ischemic cells or infarct tissue because you don't have a next cardiomyocyte to sort of propagate that signal further on. So what you're essentially using is one which doesn't actually affect the depolarization phase. So can you see on this case, we're not affecting that initial upward curve. And that's why it's beneficial for patients who have had post-MI and there's infarct tissue as well. So like I said, I'm not going to go too much into that, but that's the reason why it's used there. Moving on swiftly. So in terms of class 1C, these are probably your most potent sodium channel blockers that we see. A lot of these can be problematic. So flecainide we use in SVT only. We don't use it in any ventricular arrhythmias, particularly because it's contraindicated. It's used in any sort of structural issues, any sort of heart failure, and so on, because it reduces cardiac output. But as you can see here, we don't get a change in the repolarization phase. Remember, these are sodium channel blockers, and we were predominantly concerned with the initial uprise of that slope. So compared to our first one, I'm just going to quickly go back. Look at the difference in terms of angle. So we've got a slight angle on the class 1A, but when we look at our class 1C, we've got a significant decrease in terms of significant increase in sodium channel blockage, which is preventing the depolarization phase. Okay. I'm gonna sort of jump forward and jump back a little bit. We're gonna go into class 3 very quickly. Class 3 are potassium channel blockers, and the most common potassium channel blocker that you'll know is amiodarone. So it's part of our sort of research protocols, and very much this affects. Remember we talked about potassium channel blocking. If you block potassium channel, you're essentially preventing that repolarization phase. So as you can see on this slope here, that's the black line is our normal repolarization, and when we use amiodarone, what we're getting is we're getting a delay and a slowed sort of repolarization back to the resting membrane potential. And hopefully you can see why it was very important to go through that initial action potential, because without going through that, none of this would really make any sense. Amiodarone is one of these potassium channel blockers that we use. There's a couple of others that are listed on there, dronadrone and sotalol. That again, we do have the option to. Abutilide is not one that we would use here. The good thing about amiodarone is that actually, despite that notion that I mentioned previously that many antiarrhythmics are also proarrhythmics, amiodarone actually has low proarrhythmic profile. So it's pretty good in actually not inducing arrhythmias. The problem with amiodarone actually comes from really its side effects. So actually doing the baseline investigations, your chest x-rays, your TFTs, your pulmonary function tests, or liver function tests as well. And the fact that actually it's got an iodine base, so patients with thyroid disorders or thyroid problems may not tolerate the medication or well from a thyroid perspective, from an endocrine perspective. The other thing about amiodarone that we've got to be careful of is it has an extremely long half-life. So in most of us, the half-life of amiodarone would be about 2 months. In our elderly population, that would probably extend to about 3 months, and it's something that we generally I think manage amiodarone quite well. I think the only sort of point I would say on that is really in acute presentations where patients are given amiodarone centrally. We've just got to be careful of the rate and sort of the dilution and giving it neat from an administration perspective. But of course, a burnt limb or is probably better than not in most cases not being here. So we do allow for that in exceptional circumstances, and it's part of the research protocol. The other thing is really on the other side of it where we are discontinuing amiodarone is I think we sometimes forget to continue the monitoring beyond the discontinuation period. So actually what we should be doing is continuing a further set of TFDs and LFDs for at least 3 months after stopping amiodarone because of its long half-life. So just because we are not getting the desired efficacy from the agent and we've stopped it, adverse effects due to metabolites and the fact that it still remains in your system, it can still be seen, can still be there. So it's important to obviously continue that. And generally speaking, just it's one of our go-to agents. So in our sort of in our sort of vocabulary and our sort of dictionary of drugs, amiodarone is very much an agent that we can use across all arrhythmias. For our cardiovergent patients, we tend to load them and put them on because actually there's a higher chance of success while patients are on there. So it's generally a well-accepted drug overall. Again, I'm just gonna go rather than going next one, so I'm going a little bit back. Just there's a good reason for that. What I'm going to just very quickly talk about is we've talked about the two rhythm control classes, which is class 1 and class 3. Class 2 is beta blockers. So what we're saying is even though these are classed under the Walls-Williams classification as antiarrhythmics, beta blockers are not antiarrhythmics as such. They are very much rate control medications. There's a whole host of beta blockers which exist. Some of these medications are selective to beta 1. Some of those are not selective to beta 1. So beta 1 is our sort of main adrenal receptor located in the myocardium, located in the sinoatrial node, to which beta blockers bind. And there's a reduction in heart rate which is seen. There are some beta blockers which also have alpha blocking properties, so such as carvedilol. So as well as having an effect on heart rate, these are alpha 1 effects or vasodilating effects peripherally. So anyone who is hemodynamically unstable from a blood pressure perspective, you've got to be careful in using beta blockers in those patients. I mean, that it's probably the same for bisoprolol. We do see patients who, even bisoprolol and metoprolol, tend to have a effect on blood pressure. Metoprolol less so, but again, it does occur, and obviously there may be a case for withholding that medication or reducing the dose and so on. So what do beta blockers do? Well, beta blockers, like I said, they work on beta 1 adrenal receptors. There's this misnomer, or this misunderstanding that beta blockers reduce heart rate. Now, what I want to sort of very quickly nip in the bud is actually beta blockers in itself themselves don't really reduce heart rate. What they do is they prevent the binding of sympathetic ligands such as noradrenaline and adrenaline to bind to the beta 1 receptors, and as a result of them not binding, or a lack of numbers of noradrenaline binding to the beta 1 receptors, we see a reduction in heart rate. But by molecules themselves, bisoprolol is a beta blocker. It's an antagonist. It's a beta adrenergic antagonist. And antagonists don't have an effect, don't have opposite effect. Where there's confusion, and what a lot of people get confused with, is a term that's known as so we know agonists, we know antagonists. The next term is something known as inverse agonists. So inverse agonists are actually drugs which hit the drug into reverse, or hit the receptor into reverse. So agonists drive forward a ligand, drive forward the receptor activity at receptor. Antagonists block and are very much the brakes, and inverse agonists are very much the reverse gear in terms of driving activity at the receptor back. So there are some agents which would truly drive heart rate down, and those are the terms. And in that case, that's when we would truly use that this agent is a negatively chronotropic agent, because it's an inverse agonist. Bisoprolol, it has negative chronotropic effects, and the outcome is a reduction in heart rate, but by molecule itself, it doesn't drive, it blocks. Blocks the activity of adrenaline and so on. The other thing, obviously, in terms of the advantage of beta blockers, is by seeing a reduction in heart rate, particularly for our angina and MI patients, is we allow prolongation of diastole. Prolongation of diastole allows for distal regions within the myocardium, particularly those patients who suffer sort of atypical angina, or sort of any sort of coronary spasms and so on, for those distal regions to be perfused, because patients are now running at there's adequate blood flow to those regions. There's enough time because of beta blocking effects for those distal regions to be innovative with sort of oxygenated blood. Beta blockers tend to be our go-to therapy in terms of rate control. The time where we would not use beta blockers, so this is a question that I had a few weeks ago, was actually, but when would we actually not use beta blockers for rate control? Of course, if patient has any significant respiratory disease, asthma, that's significant. In patients who require it for long-term therapy, my advice always is to undertake peak flow and spirometry pre-beta blocker, give them a trial dose while they're on the ward, and then do a post-dose spirometry within sort of an hour, and then follow maybe 1 hour, let's say, sort of 4 hours, once those effects are reduced. And again, it's not a contraindication, it's a caution. The other time where you would probably not use the beta blockers as much is if there is significant nodal dysfunction, or particularly AV nodal activity. AV nodal blocking drugs are preferably calcium channel blockers. So when we talk about rate control with beta blockers and calcium channel blockers, if it's very much driven by idiopathic or sort of sinoatrial dysfunction, beta blockers tend to be a bit more better, because actually they work on beta 1 receptors located predominantly within the sinoatrial node. However, if there is any other atrial tissue which is the cause of concern, or any sort of AV predominantly driven by sort of AV atrioventricular nodal dysfunction, then you'll see a lot more of the cardiologists recommend calcium channel blockers in the form of diltiazem or verapamil being used. The advantage that beta blockers do have over calcium channel blockers is that they don't reduce cardiac output. Calcium channel blockers, by name, what they do is they block the entry of calcium within the cardiomyocyte. The problem with not allowing calcium to enter the cardiomyocyte is you don't get the troponin binded squeeze that we see from calcium. So calcium's function, quite simply, is to squeeze, is to cause muscle contraction of some sort. So by blocking entry of calcium within a myocyte, we actually reduce the amount of squeeze that there is, and that's not great for patients who have heart failure or a reduced cardiac output in that sense. So that's beta blockers. So just to again summarize that very quickly, they're not antiarrhythmics. Even though they're in this classification, they're very much driven by rate control, and they are class 2. Out of all the drugs that are used across cardiovascular medicine, beta blockers are the most prevalent, even higher than ACE inhibitors, MRAs, antiplatelets. We use beta blockers in heart failure. We use beta blockers in angina. We use beta blockers in the management of arrhythmias. So really here to stay. If patients have adverse reactions and intolerances, please, please, please do try to define what those are. Otherwise, we could possibly avoid them having a good therapy. Deny him sort of good standard of care as such. Very quickly, just this slide in terms of selectivity on the left hand side. So which ones are more selective to beta 1? So those which ones say no would be selective for other receptors, either alpha 1 or beta 2. Beta 2 tends to be a problem because that would induce bronchospasms in patients and so on. And have I got it in here? Just the other thing in terms of lipid solubility, anything that's highly lipid soluble tends to cross the blood-brain barrier a lot more. So you're more likely to, this is across medicine in most cases, not just beta blockers, you tend to see a lot more CNS side effects. So for example, on this list, we've got propranolol. So propranolol, actually one of the side effects, if you go away and have a look, is very much drowsiness, and it's also vivid dreams, anything sort of neuro related, and that's because it's highly lipid soluble, it crosses the blood-brain barrier and so on. Last thing on beta blockers very quickly, and we move on, is we tend to, I get this question often as to actually bisoprolol is licensed once a day, but we have our cardiologists prescribing it twice a day, or in most cases, same with ACE inhibitors. So ACE inhibitors are licensed, or Rampril is licensed once a day. Why do we prescribe it twice a day? The answer to that is very much quite simply to avoid any peaks. Okay, so what we realize in heart failure, for example, we recognize the higher the dose of beta blockers, the higher the dose of bisoprolol, the better effect and impact of that treatment we're going to see in those patients. With the better prognosis that there is, the reduction in mortality that we're going to see is better at higher doses. But what we don't want is, we don't want this compromising the patient's blood pressure. We don't want this compromising the patient's ability to function on a daily basis, and therefore what we're going to do is we're going to give them a cumulative dose of 10 milligrams, but we're going to split it over 2 doses of 5 milligrams twice a day. What else the second benefit of doing that actually is we don't see a tail off of effect over the night. So that might not be a problem for most patients, but to ensure we've got a good steady state concentration, which is again more important in heart failure, because we're here for the long-term thing in heart failure, than it is for acute arrhythmia management, where you want to get on top of the arrhythmia. You probably may prefer the BD dosing in heart failure than you would in arrhythmia. So again, it would make little sense in the acute management of an SVT for someone to go on to 5 milligrams twice a day of bisoprolol, because actually it defeats the objective of getting on top of the arrhythmia. You might as well just reduce the overall dose initially, get on top of it, and then retitrate that medication. And that sort of supplements our last class. I'll come back to this. That class 4 calcium channel blockers very much decrease heart rate, because they block a lot of activity at the AV node, which is the gatekeeper to the heart. And generally speaking, again, they are quite potent. Orally, under cardiology advice, we do use beta blockers and calcium channel blockers, Rayleigh and calcium channel blockers together. What I would advise is I would certainly be concerned if there was IV beta blockers and calcium channel blockers used concomitantly. That would be in most cases an absolute contraindication. there have been, I won't talk too much about it, there have been cases where that's led to sort of national issues with that happening. But in terms of oral beta blockers and calcium channel blockers, as long as they've been sort of recommended and acknowledged by sort of cardiologist or a registrar, then that may be okay. Like I said, in terms of heart failure, we'd avoid using this class of drugs just because they would reduce cardiac output. A lot of calcium channel blockers tend to have a lot of drug interactions, and there may be a case where you need to reduce the dose down, and usually that kind of works. The main sort of side effects that we need to be careful of with all calcium channel blockers, even our sort of ones that we use in hypertension and dihydropyridines and non-dihydropyridines, is very much around fluid overload and edema. We tend to see that a lot more with amlodipine and so on. The other question that I often get asked is, can you use diltiazem, a rate control calcium channel blocker, and sort of, let's say, amlodipine together? That's okay. I would probably want to explore why patients reach that point. Why were they not able to have a beta blocker? Have they been challenged on a beta blocker before or not? Ideally, it would be beta blocker and amlodipine, but there may be cases where patients go on to diltiazem and have such amlodipine for the hypertension and so on. And like I said, that's not an absolute contraindication because the mechanisms are different beyond there, but just make sure it makes there's a logical approach in getting to that point. Just looking at the time. The biggest question that I'm often asked with is, or the most prevalent question I'm often asked with is around QT prolongation. And that is a full session on its own. I'm not going to go into that massively, but just to summarize it, QT prolongation is all to do with this slide. A lot of it's to do with this slide, unless it's QT acquired sort of log QT syndrome, sorry, which is different. So what we're talking about is we're talking about drug-induced QT prolongation. I'm sure you've probably come across notes where pharmacy colleagues have written in, caution, do not use QT prolongation. And actually, it depends on the situation. In summary, so what we're saying is that the risk of QT prolongation is very much the fact that the QRS complex is prolonged and maybe the ST segment is also prolonged, or a combination of both, or a combination of one. Now, of course, if patients have a bundle, we expect, well, there may be an expectation that there is QT prolongation, so we need to account for that. The risk of QT prolongation is that essentially it is proarrhythmogenic. It will lead to torsade de points, and that could eventually lead to patient going to VTVF, and that's why we are concerned. Now, what I would do is, if you ever encounter sort of patients being on QT prolongation drugs, is speak to pharmacy or establish yourself the risk of that drug, first of all, prolonging QT, and by how much. So our antipsychotic medications prolong QT, but they do that in varying degrees. So one thing that I try to do is establish by how many milliseconds QT prolongation would occur, or estimate to occur in a particular agent. Of course, the higher number of agents, the more likely that's going to occur. The second thing that we obviously need to do is recognize where there's any reason for that QT prolongation, so, and account for that. So as I mentioned previously, around sort of QT, any left bundle branch block, which would have some bias in that calculation of QT, and that would require what we call an adjusted calculation of corrected QT prolongation. Thirdly, we need to obviously establish what the heart rate is and adjust for that. Of course, a patient who is tachycardic on ECG, we're less likely to see that QT prolongation on there. So we need to, again, account for any heart rate problems that are seen. Number 4, patients who are in heart block may, by the fact that they're bradycardic, present as or display QT prolongation. In actual fact, There's no morphology change. The actual QT segment is okay. And again, once you adjust for heart rate or once there's pacemaker's been inserted, it's probably advisable to calculate the QT then, and usually it's fine. And the next thing that we just need to be mindful of really is many drugs which cause QT prolongation because they inhibit this gene that's listed on here. So I'm not going to talk about it too much, but this is the reason why our antipsychotics cause QT prolongation, because they inhibit potassium repolarization in some shape, in some form. The inhibition of potassium is called IKR, so it's the fast current of potassium repolarization is inhibited due to some of the way these drugs are made or what they look like. And what we tend to see as part of sort of drug development is that a lot of pharmaceutical companies try to use this as a marker in sort of developing their drugs to avoid this gene. Now, patients who have a mutation in this gene are those patients who are likely to then go on to be found with sort of long QT syndrome and so on and so forth. Like I said, it's a very complex issue in there, but there's hopefully a few things around why QT prolongation occurs. I mentioned amiodarone is a potassium channel blocker, and therefore what we're saying is this class of drug, and hopefully you can work with me on this, is this class of drug actually by default is QT prolonging. Because what do? They delay that sort of repolarization phase. Now, just because drugs are QT prolonging, most drugs do have a translation, do translate to a TDP risk. Amiodarone is one exception. So we said that it's actually not pro-arrhythmic, and one of the reasons why it's not is actually its torsadogenicity is pretty low. So actually, yes, you may have QT prolongation with amiodarone, but while patients are on amiodarone, the risk of TDB is pretty low. The evidence suggests it's pretty low. That's opposed to any of the other potassium channel blockers. So again, if you go away and have a look at dronadrone and sotalol and albuterol, actually they do have a big risk of TDP and VF and so on. And that's in the background the reason why we use amiodarone for all arrhythmias on there. Sotalol, by the way, is a beta blocker. It does have beta blocking properties, but it also has potassium channel blocking properties. So it's got a dual action on there. Just going to go forward on this. Atropine, as I said, managed and used initially as per sort of the tachycardic algorithm that we present that I showed to you. So go away and have a look at that. You can use an unlicensed dose in asystole at 3 milligrams. It is an antimuscarinic, and as with all antimuscarinics, a relative contraindication would be those things that are listed on this slide in there. So very much anything about slowing down and increasing parasympathetic sort of innovation. Digoxin, we'll talk a little bit more about this next week on our sort of therapeutic drug monitoring sort of slide. From this perspective, what I just want to say to you is generally digoxin is used for two reasons. Number one, for its antiarrhythmic sort of effects or rate effects. And secondly, due to heart failure. So it's got a negatively chronotropic effect and a positively inotropic effect. Generally speaking, digoxin does not really improve mortality. It reduces hospitalization. In actual fact, there is some evidence or old evidence to say actually increases certain sort of acute mortality or long-term mortality, acute mortality because it's a high-risk drug and there's a risk of digoxin toxicity. So when you add that into the equation, it's not as straightforward as it seems when it comes to dosing. So a lot of your centers Hi guys, can you hear me again?
Yeah, you're back.
I'm back. We're nearly there. So in terms of obviously digoxin, well, like I said, we'll talk a little bit more about the effects of it. But what we're trying to do is we're increasing the amount of calcium which is within the cardiomyocyte, and therefore we're increasing that sort of inotropic effect on the more calcium that's in causes a reduction in heart rate. So that's why we see a negative inotropic effect. But we'll allude to this a lot more next week when we do that. So we can skip this bit. Oops. So to duplicate slide. Adenosine again. The only real thing that I wanted to mention on adenosine is we sometimes see patients who are on dual antiplatelet therapy with ticagrelor. We just see patients who come in with heart block who are on ticagrelor. And one of the contraindications of ticagrelor is any conduction issues, any heart block, and so on. And the reason why we change patients off ticagrelor in such a case is because ticagrelor inhibits this adenosine pathway and therefore sort of reduces the amount of adenosine which is circulating and therefore causing a reduction in heart rate and increasing the risk of conduction issues and heart block as well. So ticagrelor, yeah, in terms of animal conduction issues and heart block, it's an agent that we would usually change across. That shortness of breath that patients might complain of tends to be pretty early on. Of course, it's not to be confused with any other differentials that you have, any other sort of heart failure symptoms on there. But if you do suspect it's drug induced, it may well be ticagrelor related. I think the easiest way to usually see it is if you discontinue the medication um, uh, and substitute it with either prasugrel, particularly if they've had a stent. And of course they've not had any sort of CVA or bleed, of course, then that may be appropriate. But by no means am I saying to you you need to do that for all patients, particularly antiplatelets. It's very individualized. A lot of our PCA is dictated, of course, by here or other by what's going on with the interventionists who have done the angio, have seen the coronary vessels, and so on. I know Sheffield have recently changed their management of patients with STEMI and moved across to sort of using a lot more prasugrel. Of course, that's with the caveat that the patient is not older than 75 and they've not had a CVA bleed in there. But yeah, just be careful with ticagrelor and it inducing or contributing to any conduction issues and arrhythmias on there. Ablation cardioversion, of course, if patients are not suitable, then these are the things which would be tried. There's just one thing on that. There was a slide that I skipped before about a young child coming in. We just want to very quickly just go back to that, and then we'll finish. Just so this, I leave this on there. So this is a child who's been brought in by ambulance in cardiac arrest, struck to the chest. I've taken this off the Life in the Fastlane website. You can go and visit and have a look if it's there. But very simply, this patient was in full arrest, VF, and then a systole. Toxicology report comes back normal. Forensic pathologist puts the cause of death as commotion cortis. Findings were normal pericardial sac, normal coronaries, no atherosclerosis, everything was fine. And this was really just an example of something known as the R on T phenomena. So very much this child got struck with the ball at the time his heart was going through the T wave. And what we realize is that the R complex is very much the shock, is the punch. So when we experience, or if someone experiences what we call an R, so an R complex on T, R on T phenomena, they are at an increased risk of, particularly during this sort of upstroke, at risk of going into EF in this case. So it's quite unfortunate. But that's why when you go back to our case, which I'm sure sorry, what will make more sense to you now is when we have our cardioversions, one of the terminologies that's used is synchronized cardioversions, and the synchronized on it is really to prevent the shock on the R wave. So we don't shock on the R wave, and obviously when you do a synchronized cardioversion, it avoids that R on T phenomena there. And then I'll just leave this slide on there. Just again, hopefully you should know some of this, but it's just very much electrolytes and how they sort of predispose arrhythmias and sort of the effects on there. The one that I'll mention is very quickly hyperkalemia. Hyperkalemia is often associated with sort of it being a cardiac emergency. And the first thing that we do in cases, this is a really good example. The first thing that we do in cases of hyperkalemia or emergency life-threatening hyperkalemia is we give calcium gluconate. And the reason we do calcium gluconate is often people say it's to stabilize the myocardium. But what do we actually mean? What we're trying to say very simply is that there is so much potassium that's circulating that it's going to affect, it's going to cause a massive QRS complex. So we're going to see these pointed T waves. We're going to see the effect of repolarization occurring a lot more. Now, what we alluded to when we looked at the action potential was actually what we need potassium and calcium being in equilibrium, having however much potassium we have, we need to sort of account for that calcium level. So the reason why we give calcium gluconate is to stabilize the myocardium, but it's more to stabilize the membrane potential. It's to stabilize the effects of excessive potassium that's circulating. But yeah, so otherwise we would predispose our patients to, again, more arrhythmias on that. I've gone over time. I think we started a little bit late, but hopefully that's okay. I'm happy to take questions if there are any, and I'll just leave it there.
Thanks, Suklam. I'll just wait to see if there's any questions in the chat. I don't know if you can see the chat, but Haley has asked, do you need to tell patients to wear sunblock due to the increased phototoxicity with amiodarone?
Yeah, I mean, we do say that. The only thing that I'd probably, so yes, the answer is we would advise patients to wear sunblock, particularly if they're out in direct sunlight, but also just to counsel them on the fact that there is a possibility of a grey tinge to the skin, and that's very much again just to do with how amiodarone's sort of made up, so sort of a slight grey tinge to the skin, to the nails, and so on can be expected while being in amiodarone.
Hi, thanks very much, Jacqueline. My name's Hayley, and I'm not sure if you can see, but it was really interesting. So thanks for that. I just wondered if you'd heard of or seen many instances of, with these high use of these energy drinks like Monster and Red Bull, and the growing incidence of like younger people having like arrhythmias with that, because there was like a paper on it in, I think it was in America and Canada, where that was becoming a bit of a phenomena. Just wondered if you'd come across that.
Yeah, I think when it's sort of drug induced, and particularly, I mean, I've not seen the paper, and I'm like I said, what type of arrhythmias were they? Were they very much
so they went into
SVTs?
VT and
VTs?
Yeah, SVT, VT. There was a cardiac arrest in like a 30-year-old. I think they were doing like a bit of incidents in like an ED in I think it was in Canada. Yeah.
I mean, particularly with any sort of supplements, energy drinks, any sort of I don't know, even sort of bodybuilding supplements that are often on the market these days. I think the two things I'll say is, obviously, if there's anything which is going to have a sympathomimetic effect, so in terms of caffeine, people may have good intentions. Some people use it as a diuretic, if anything, but actually it depends on an individual's threshold. So some people just run a low threshold where they will experience arrhythmias just by having caffeinated drinks. Others have a higher threshold where actually they can get through quite a bit without having that. So yeah, I can see why that would certainly lead to arrhythmias. In terms of other things in there, I think I think where the cause for concern is that we don't entirely understand the effects of all ingredients within food products, within supplements on there, and we kind of really accept. When I say used and we are, I'm talking about generally in society, we kind of accept the commercials, the commercialized aspect of it. And I see a lot of patients who, you're right, who come in on supplements, not just in terms of drinks, but actual protein shakes, androgen boosting effects, and so on. And actually, it's very much they're on them because of sort of it being commercialized. A lot of these medications contain estrogen affecting drugs, androgen affecting drugs. They don't lie. It's listed in the ingredients. But estrogen, for example, we see quite a few patients on estrogen modifying drugs, which affects the heart. Estrogen receptor supplements, which would cause patients to have an MI and so on. So I think it is more prevalent. I think it's due to more risky behavior rather than what's in there, because actually manufacturers do have particularly if you're buying it from some of the sort of big companies, they will have a requirement to list everything, and they're not hiding behind it. It's really an education thing. It's more, do we actually know what's in those things? But clearly anything that's going to drive heart rate up, any sympathetic activity is going to induce those effects. Anything that's going to affect estrogen or testosterone is going to have an effect on the heart as well. So yeah.
Yeah, thank you. I think it's just worth asking these questions, isn't it? Like you say, the riskier behaviour now probably needs to be a little bit more appropriate, kind of asking about history. So not just looking at the medical history medication history, but asking them, what are they eating? What supplements are they taking? What kind of foods do they eat? I know you can't ask everything exhaustive, but having an idea that can happen as well with those types of food stuff, isn't it? Yeah, being a bit more subsequent with your clinical history taking. Thank you.
I think, are we done, guys, yet?
Yeah, there's no more questions in the chat at the moment.
Yeah. Wonderful, guys. Thanks so much. Obviously, we are technology to put away. Then I'm usually a face-to-face person, but it works. Teams works. I think it works when there's people across sites as well. So thank you for listening in, and